Now coming to the exposition or explanation of qualitative platelet disorders, we have the classification here. I have shown this in the previous video also. So this is the classification of platelet function disorders or qualitative disorders. We have hereditary and acquired. We will go into one by one. First, let's have a look at the hereditary disorders. So we have again three classifications over here. First we have defects of addition, disorders of platelet secretion, and defects of aggregation. So first let's look into the defects of adhesion. So two factors are important for adhesion of platelets to subintracellular matrix during normal hemostasis. One being the platelet membrane glycoprotein 1b9, and then we have the which is the receptor for the other factor, that is von Willebrand factor. So in case of there is a condition called Bernard-Seller syndrome or giant platelet syndrome. It is an autosomal recessive disorder due to the hereditary deficiency of the platelet membrane GP1b9. So in case of Bernard-Seller syndrome, this receptor will not be there, or it will be deficient in Bernard-Seller syndrome. Now we have von Willebrand disease. It is characterized by the reduced synthesis of von Willebrand factor, as a result of which platelet addition to subendothelial collagen is defective. So von Willebrand factor gets attached to GP1b9, since this is a receptor for von Willebrand factor. So if GP1b9 is missing, then how can von Willebrand factor get attached to GB1b9? So in case of Bernard-Seller syndrome, it is always associated with von Willebrand disease. But then, since von Willebrand factor is a plasma protein disorder rather than a platelet functional disorder, it is often discussed with other coagulation disorders. Now we have disorders of platelet secretion. So defect in the secretion may be due to lack of normal storage granules. It could be either alpha granules or dense granules, or due to defect in the release of granules, namely dense granules and alpha granules. That is, these granules have different substances that they release. So there could be a defect in the release from this granules. So in case of storage pool deficiency, we have we have a deficiency in the dense granules. So dense granules, it usually secretes like ATP, serotonin, and calcium. So these secretions or these substances are not being released, or it may be because dense granules are completely absent. So in case of storage pool deficiency, there won't be dense granules. In case of Gray platelet syndrome, we have a lack or absence of alpha granules. So alpha granules releases substances like adhesive proteins like fibrinogen, von Willebrand factor, fibronectin, or thrombospondin, and growth factors like BTGF, DGF, beta, thrombospondin, platelet factor 4. All these growth factors are released from alpha granules. And then we have coagulation factors like fibrinogen, factor 5 or factor 9. So all these substances are produced by alpha granules. So in case of Gray platelet syndrome, is due to the lack of alpha granulose proteins, because of which the platelets and megakaryocytes appears gray or gray on peripheral blood smear. Now lastly we have defective platelet aggregation. So we have Klansman's thrombosthenia, which is an autosomal recessive disorder, and it is due to the deficiency of glycoprotein 2b3a. This is the GB2b3a. It is a protein complex that helps in the formation of breaches between platelets by binding fibrinogen. So this is a fibrinogen. So this fibrinogen and fibrinogen gets attached because they are being attached to the GB2b3a. So these are two platelets and they are being attached by fibrinogen, and it forms breaches between platelets. But then there is a defective aggregation of platelets in response to platelet aggregators like adenosine diphosphate, collagen, epinephrine, or thrombin. And clinical presentations is in the form of epistaxis, that is nosebleeds, and bleeding from gums. So Klansman's thrombosthenia suggests a defective platelet aggregation where GB2b3a is absent or is deficient. Now coming to acquired defects of platelet function. Drugs, numerous. We have drugs, renal failure, and hematological malignancies. So for drugs, numerous therapeutic drugs can affect platelet function, but most importantly are the aspirin and other non-steroidal anti-inflammatory drugs, or NSAIDs. And then metabolism of arachidonic acids require enzyme called cyclooxygenase for the synthesis of platelet aggregator thromboxane A2. And then aspirin is a potent irreversible inhibitor of the enzyme cyclooxygenase. And this platelet anti-aggregating effect of aspirin in the basis for its use is in the prevention of thrombosis in cases of CAD, that is coronary artery disease, or cerebrovascular stroke. And the defective aggregation lasts for almost 7 to 10 days, even after a low dose of 60 mg aspirin. And then coming to next, we have the renal failure. Uremia produces several abnormalities in platelet function. Coming to the last, we have the hematological malignancies. So in myeloproliferative neoplasms and myelodysplastic syndromes, platelet dysfunction is due to intrinsic platelet defects. So that is all about the defects, functional disorders of platelet. So let's summarize the video.